Have you ever found yourself trying to interpret signals from your own body? Signals that are confusing, maybe inconvenient, and sometimes, frankly, pretty worrying.
Oh, absolutely. We've all been there.
Yeah. So today we're embarking on a deep dive into a topic that affects, well, countless individuals, but is often shrouded in misunderstanding and maybe quiet concern: abnormal vaginal bleeding.
It really is such a common experience, yet the nuances can be incredibly complex. Um, our mission with this deep dive is basically to unpack a comprehensive medical standard on this very topic, give you a shortcut to being well-informed.
Okay.
We're going to try and simplify it, clarify what's truly considered abnormal,
Yeah.
explore its varied causes across different life stages, discuss how it's diagnosed, and outline the range of treatment options available.
Yeah.
The goal is for you to walk away feeling, empowered with a clearer understanding of your body.
Okay, so if our bodies are sending these confusing signals, where do we even begin to decode them? Like, we need a starting point, right? A baseline.
Exactly. A foundational understanding, a Rosetta Stone, like you said, for what abnormal vaginal bleeding truly means.
Because it's definitely not a one-size-fits-all definition, is it?
Absolutely not. And here's where the real insight begins, I think. The medical standard essentially says, your body, your baseline. Abnormal bleeding is fundamentally defined by what's different for you,
Okay.
not some universal number. And this empowers you, the listener, to be the first and honestly the most crucial expert on your own body. What's normal for one person could be a significant symptom for another, and that personalized perception is, well, it's paramount.
That emphasis on personal perception, that really is vital. It kind of shifts the dynamic, doesn't it?
It really does.
But beyond that individual baseline, what are the specific categories, maybe the terms, healthcare providers use to classify these different patterns of bleeding?
Okay, yeah. The standard provides crucial clarity here. First, there's heavy menstrual blood loss. This is cyclic bleeding, so it happens with your period during your reproductive years, and it's heavy enough to genuinely disrupt your daily life.
Disrupt to daily life. That's the key phrase.
Exactly.
Yeah.
And it's so important to remember that your perception of heavy, how it impacts you, like, needing to change protection constantly or missing work, that's paramount. Even if objective measurements, like maybe losing over 80 milliliters, don't always align with that feeling.
Right.
And this type, by the way, can often lead to iron deficiency anemia, which is a significant health concern in itself.
Makes sense. I can see how that subjective impact would be key. But what about the bleeding that feels completely unpredictable? Like, it breaks free from any discernible rhythm. How do we categorize those more erratic signals?
Yeah, good question. Those more erratic signals fall into a few categories. Irregular blood loss is non-cyclic bleeding, where individual menstruations are no longer recognizable. It's just, irregular.
Okay, no clear periods anymore.
Pretty much. Then we have intermenstrual blood loss. This is specifically bleeding that occurs between those recognizable menstrual periods.
So spotting between periods, maybe?
It could be spotting, or it could be heavier. It might be consistent, or it might just pop up sporadically.
Gotcha. And what if someone experiences something sudden and really, really severe?
Okay, that would be acute heavy blood loss. That's severe bleeding requiring immediate medical treatment, like go to the ER kind of bleeding.
Okay.
There's also contact bleeding, which is bleeding that happens after sexual intercourse or, say, an internal physical examination like a pap smear.
Right.
And finally, a very important one for those beyond their reproductive years, postmenopausal blood loss. This is any bleeding occurring more than 1 year after your last menstruation.
And that one always needs checking out.
Always. This type of bleeding always warrants close attention and investigation.
Okay. We've now laid out a clearer framework for what constitutes abnormal bleeding. But to really empower our listeners, we need to understand the why. And that journey into the causes, I imagine, has to begin with the incredibly sophisticated mechanics of the menstrual cycle itself, doesn't it?
It absolutely does. You have to understand the baseline first. The menstrual cycle is this finely tuned dance involving your brain, your ovaries, and your uterus.
Right, hormones.
Exactly. Hormone shifts, primarily estrogen and progesterone, they meticulously regulate the thickening and then the shedding of the endometrial lining in your uterus. A normal cycle can actually vary quite a bit. Anywhere from 21 to 35 days is generally considered normal.
That's a wider range than some people might think.
It is. And here's a common point of natural variation. Anovulatory cycles, where ovulation doesn't actually occur in a cycle. They're quite common in the first few years after menarche, your first period, and then again in the years leading up to menopause. These natural hormonal fluctuations can lead to some perfectly normal irregularities sometimes.
So even normal has quite a wide spectrum of natural variation.
Okay. But beyond those physiological shifts, for those in their reproductive years, what are the more common, perhaps surprising causes of heavy menstrual bleeding?
Okay, so for heavy bleeding, a very common cause often involves uterine structures. We're talking about conditions like myomas, more commonly known as fibroids.
Fibroids, yeah, I've heard of those.
Right, they're benign growths in the uterus and adenomyosis. That's where the endometrial tissue, the lining, actually grows into the muscular wall of the uterus.
Into the muscle itself, wow.
Yeah, and what's fascinating here with myomas or fibroids is that they're particularly common in women aged 30 up to menopause. And strikingly, they're over 3 times more prevalent in women of West African descent.
That's a really significant demographic detail.
It is. And the size and, crucially, the location of these myomas can greatly influence the amount of bleeding you experience. A small one in the wrong place can cause more trouble than a larger one elsewhere.
Interesting. What other factors, perhaps less intuitive ones, can influence heavy bleeding? Well, beyond structural issues, contraception can be a factor.
Mm.
For instance, copper IUDs are known to potentially increase bleeding, especially in the first 3 months or so after placement.
Okay.
Certain medications can also play a role. Things like anticoagulants, blood thinners make sense, right?
Mm-hmm.
But also misoprostol, corticosteroids, and even some antidepressants like SSRIs can contribute.
SSRIs too. Okay. We've covered some usual suspects, but what about those less obvious conditions? Things that a listener might never connect to heavy bleeding. Are there any that often emerge during diagnosis that really catch patients off guard?
There certainly are. Coagulation disorders like von Willebrand disease should absolutely be considered.
A bleeding disorder.
Exactly. It affects how your blood clots. This is especially true if heavy bleeding began right at menarche, your first period, or if there's a family history of bleeding issues.
Right.
And what's really interesting is that studies show von Willebrand disease can be found in like 13 to 20% of women with objectively heavy menstrual bleeding.
Wow, that's quite high.
It is surprisingly common. And sometimes, even after extensive investigation, no specific cause is found. This is termed essential heavy menstrual bleeding.
Meaning they just don't know why.
Essentially, yes. It's thought that maybe a physiological genetic variation in how the uterine lining controls bleeding, what we call endometrial hemostasis, might play a role.
Like a subtle natural difference in your body's built-in clotting mechanism just in that specific area.
That's a good way to put it, yeah.
Okay, that's a deep dive into heavy bleeding. Now let's shift gears a bit to irregular or intermenstrual bleeding during the reproductive years. What are the common culprits there?
Yeah, so for the irregular stuff, often these are, as we kind of touched on, physiological reactions to changing hormone levels, especially common in those early teenage years and later perimenopausal years when cycles can frequently be anovulatory.
Right, the body's still figuring things out or winding down.
Exactly. But beyond that, infections are a significant cause. Chlamydia infections, for instance, causing cervicitis, which is inflammation of the cervix. They're a major driver of intermenstrual and postcoital bleeding after sex. Studies show it occurs about 3 times more often in infected women. Pelvic inflammatory disease, PID, can also be a culprit.
I hadn't realized the strong link between STIs and these bleeding patterns. Any other surprises here?
Indeed. For those who've had a C-section, something called a niche, which is basically a little defect or pocket at the C-section scar in the uterus, can cause intermenstrual or postmenstrual spotting.
A niche. Really?
Yeah, and it's surprisingly common. It affects over half of women who've had a C-section. Then there are contraception side effects, of course. Hormonal contraceptives, particularly progestogen-only methods like the mini pill or implant, they can cause unpredictable bleeding initially, though this often settles down, sometimes leading to amenorrhea, no periods, or just spotting later on.
Right.
And finally, certain lifestyle factors can play a role. Like smoking, especially in combination with hormonal contraceptives, seems to increase the risk of intermenstrual bleeding.
Huh. Okay, that's quite a comprehensive list for the reproductive years. Now let's talk about postmenopause. It sounds like any bleeding at this stage is usually a very important signal, correct?
Exactly. While we certainly don't want to alarm anyone unnecessarily, it sounds like postmenopausal bleeding is one of those symptoms that truly always warrants a thorough investigation.
Always. Okay.
Even if the vast majority of cases turn out to be benign. Approximately 10% of these cases are linked to endometrial carcinoma, cancer of the uterine lining, and this risk actually increases significantly with age. Certain medications can also subtly increase this risk, like tamoxifen, which is often used for breast cancer treatment.
Right, you mentioned that.
Yeah, it carries a slightly increased risk of endometrial carcinoma due to its mild estrogenic effect on the uterus. Sort of stimulates the lining a little bit.
So it's not always a benign cause, but it's important to know that benign causes are still more common, right?
Oh, absolutely. Very important point. Common benign causes like endometrial polyps or endocervical polyps, little growths, they account for over a third of cases.
Okay.
And quite reassuringly, in at least half of cases, additional investigation reveals a normal, or what we call an atrophic, thinned-out endometrium, meaning no serious underlying cause is found.
That's good to know.
Yeah. And even common issues like vaginal atrophy, just thinning and dryness, can cause contact bleeding in postmenopause. So while you always get it checked out, there's a very good chance it's something quite manageable.
Okay, that covers the what and the why really well. Now for the how. How do healthcare providers actually investigate abnormal bleeding? What's that diagnostic journey like, and how can a listener maybe prepare for it?
It genuinely begins with you, with the patient. That initial conversation is paramount.
The history taking.
Exactly. Your healthcare provider will want to cover your life stage. Are you reproductive or postmenopause? The exact nature of the bleeding, any associated pain, your contraceptive use, any medications you're currently taking, your story, your observations are the first crucial piece of the puzzle.
So it truly starts with listening. What about the physical examination? Is that always part of the process?
Not always, which might surprise some people. It might be skipped, for example, for very young women in the first few years after starting their periods, or maybe those who've just started hormonal contraception and are experiencing typical initial side effects.
Okay.
When it is performed, it involves checking the external genitalia, the vagina, and the cervix, often with a speculum exam.
Right. And what are some of the key diagnostic tools they might use to get a clearer picture?
A really practical one for you, the listener, to maybe you can do beforehand, is the menstruation scorecard.
Oh, tell me about that.
This is a semi-quantitative tool where you basically rate the soakage of your pads or tampons based on a chart. You add up points. A score of 150 or more makes heavy menstrual bleeding likely.
So it helps quantify it.
It does, and I imagine for many, what feels heavy might not always align with objective measurements, or maybe it really concerns how heavy it is. It could even be surprisingly reassuring for some, couldn't it?
Yeah, absolutely. Like putting a number to something previously just felt overwhelming.
Exactly. It gives you and your doctor a common language.
That sounds incredibly empowering. What comes next after that initial assessment? Maybe the scorecard.
Beyond that, transvaginal ultrasound is a really crucial imaging technique.
Okay.
It's done with a probe inserted into the vagina, and it's especially effective for assessing the endometrium, the lining of the uterus, and identifying issues like myomas or polyps.
And when's the best time to have that done?
It's often best done in the first half of your cycle, say right after your period ends, when the endometrium is naturally thin. Things are just clearest then.
Makes sense. Is ultrasound always reliable, though? For everyone, every situation?
Good question. And here's a vital caveat, really important for our listeners to understand. For women, using tamoxifen.
The breast cancer drug.
Exactly. For those women, transvaginal ultrasound is actually not reliable for excluding endometrial carcinoma.
Oh, wow. Why not?
Because tamoxifen has these unique effects on the uterine lining, it can make it look thick or irregular on ultrasound, even when there's no cancer. So a biopsy of the endometrium, taking a small sample of the lining, is necessary in these cases. It's a non-negotiable step for anyone on tamoxifen with postmenopausal bleeding.
That's a crucial distinction. Okay.
Well,
What other tests might be involved depending on the specific situation?
other tests can include basic blood tests like an HB count, a hemoglobin check to see if there's anemia from the blood loss,
Right.
chlamydia testing, maybe other STI tests if there's a risk, and sometimes, if there are strong indications, tests for those clotting disorders we mentioned earlier.
Okay. So once a diagnosis is made, or even when there isn't maybe a clear single cause identified, how do healthcare providers approach management and treatment? Is it like a rigid preset plan, or is it more flexible?
Oh, not rigid at all. This is where the power of shared decision-making really comes in. Treatment is highly individualized.
Good.
Decisions are made collaboratively between you and your healthcare provider, taking into account several key factors.
Like what?
Well, how much the bleeding bothers you personally and impacts your daily life. That's huge. Your long-term needs and desires regarding contraception. Do you need birth control too? Whether you want to completely control your cycle, maybe even stop periods, Or if you prefer to retain menstruation, any associated pain you might be experiencing, and of course other health conditions you have and medications you are currently using. It's truly a partnership.
I really appreciate that emphasis on collaboration. So, what are some of the key medication options available to start that conversation?
We broadly divide them into non-hormonal and hormonal options. For non-hormonal, you have things like NSAIDs, non-steroidal anti-inflammatory drugs like ibuprofen or naproxen.
Like standard painkillers.
Exactly. They can reduce both blood loss and pain, which is great, typically taken only during the heaviest bleeding days. Then there's tranexamic acid.
Okay, what's that?
It's an antifibrinolytic. Essentially, it helps your body's natural clotting system work more efficiently, specifically in the uterus,
Right.
to reduce the amount of blood loss during a period.
Interesting.
But there's an important safety note here.
Hmm.
It's generally advised against if you have a personal history of blood clots, like DVT or PE, or a known clotting disorder, or even a strong family history of venous thromboembolism,
Why is that?
due to a potential, though considered rare, risk of promoting blood clots elsewhere in the body. It also should not be combined with estrogen-containing contraceptives for similar reasons.
Okay, that's a really important safety distinction.
Yeah.
Good to know. And for hormonal options, what are the primary choices?
All right, for hormonal options, the combination pill, the regular birth control pill with estrogen and progestin, can be very effective. It reduces blood loss, regulates cycles, and obviously provides contraception. Continuous use, skipping the placebo week, can even lead to amenorrhea or no bleeding at all.
Mm-hmm.
Then there's the hormonal IUD, like the Mirena or similar devices. Highly effective at reducing blood loss, often leading to amenorrhea after maybe an initial few months of irregular bleeding or spotting.
And it's long-term contraception, too.
Exactly, 5 or more years depending on the device.
Yeah.
And it can significantly reduce menstrual pain. It can even be considered with certain myomas, provided the uterus isn't excessively enlarged or distorted by them.
Okay, any others?
Finally, oral progestogens, just progestin pills, can be used short-term. They're particularly useful to quickly stop acute heavy bleeding, often working within a couple of days. Very helpful in emergency situations.
So a really powerful array of options, sounds like, tailored to the individual's unique needs. How are these approaches specifically adapted for different bleeding patterns or underlying causes we talked about?
Yeah, so for instance, for that irregular or intermenstrual bleeding without a clear structural cause like a polyp, a combination pill can often help regulate the cycle and stop the breakthrough bleeding.
Right.
If the bleeding is clearly caused by a medication you're taking, well, the approach might be adjusting the dose or switching that medication, obviously working closely with the doctor who prescribed it.
Makes sense.
And for postmenopausal bleeding, once the more serious causes like cancer have been ruled out, treatment really focuses on addressing the underlying issues, like vaginal atrophy. That can often be managed effectively with low-dose local estrogen therapy, like a cream or a ring.
Okay, that brings us to our final crucial point. Knowing when to seek further expertise. When is it time for a referral to a gynecologist or maybe another specialist?
Right? Referral to a gynecologist is important in several situations. Obvious one. If the medical treatment options we discussed are not effective, or maybe they're just not suitable for you for some reason.
Okay.
Also, for persistent contact bleeding, that bleeding after sex, even if infections are ruled out. And crucially, if you are on tamoxifen, as we stressed, an endometrial biopsy will always be needed in that scenario, usually done by a gynecologist.
Right, the tamoxifen rule.
Exactly. For postmenopausal bleeding, if that initial transvaginal ultrasound shows an endometrial lining thicker than 4 millimeter, or if the bleeding persists or comes back even after a previous investigation was normal, a referral is definitely warranted for a more thorough evaluation.
And what if a specific condition is identified that requires more than medication, like those fibroids you mentioned?
Precisely. If specific uterine conditions like large or submucosal myomas, the ones bulging into the uterine cavity, or significant adenomyosis, are found and thought to be the cause, and they require surgical intervention, that's another clear reason for referral.
And what kind of surgical options are we talking about?
Well, it depends on the issue and the person's goals, like future fertility. Options might include a myomectomy, which is surgery to remove just the fibroids, or a hysterectomy, the removal of the uterus, or maybe endometrial ablation, which destroys the uterine lining to reduce or stop bleeding.
Okay.
It's worth noting that therapeutic curettage, a D&C, which used to be common, is generally no longer recommended as a primary treatment for heavy bleeding, though it might be part of a diagnostic workup sometimes.
Got it. Are there other specialists involved in these referrals besides gynecologists?
Definitely. If there are strong indications or confirmed findings of a clotting disorder, like von Willebrand disease, then a referral to a hematologist, a blood specialist, would be absolutely necessary.
Right.
They need to ensure appropriate specialized management of that underlying condition, which goes beyond just the bleeding symptoms.
Wow, that was a truly illuminating deep dive, seriously. Today, we've journeyed through the complexities of abnormal vaginal bleeding, covering everything from, understanding its various forms and their often surprising causes across different life stages,
Hmm?
to the diagnostic tools healthcare providers use, and a really comprehensive range of tailored treatment options. And we've really highlighted the crucial role of shared decision-making in your care.
Absolutely. Emphasizing that your personal experience and preferences are absolutely key to getting the best outcomes.
Yeah. Our hope is that you, listening, now have a far clearer understanding of maybe what to look for, what questions to ask your doctor, and just the broad range of possibilities when it comes to abnormal vaginal bleeding.
Exactly. This knowledge really empowers you to have more informed, confident conversations with your healthcare provider.
So as you reflect on what we've discussed today, maybe consider this. Given the wide range of what's considered normal and abnormal in menstrual cycles, and the often subjective nature of symptoms like heaviness or disruption, how can we as individuals leverage this deeper understanding?
Interesting question.
How can we use it to not only better communicate with our own bodies, tuning into those signals, but also to truly partner with our healthcare providers, ensuring we achieve the most personalized and effective care for our reproductive health?